Module 3, the Postpartum Woman. The postpartum period is sometimes referred to as the fourth trimester, but it's called the purpurium, which involves the 6 to 12 weeks following birth. It involves three categories: the immediate postpartum period, which is the first 24 hours right after birth, the early postpartum period, or that first week after birth, and then the late postpartum period, or weeks 2 through 12. The reproductive system during postpartum period is going to gradually return to the non-pregnant size and function in the process of involution, and the uterus, cervix, and vagina return to that pre-pregnant state. So the uterus begins to contract and involute. Involution is that uterus returning to its pre-pregnant state. It seals off open blood vessels where the placenta was implanted. It's important for the nurse to monitor the fundal height, which should descend about 1 finger breadth per day until it's below the pubic bone, which will occur about day 10 to 14 postpartum. To determine the location, we put the one hand on top of the fundus, and using our fingers, we kind of measure by the width of our fingers. We call those finger breadths. We put the other hand at the base of the uterus, and that's used to help support the uterus itself. So when we do fundal massage, that we're not pushing it right out of the vagina. So we figure out where the fundus is. We may have to massage it to get it to firm up to know exactly where it is. Breastfeeding is going to release oxytocin, and this helps with uterine contractions. We can give oxytocin IM or IV to assist with that process. Early ambulation, proper nutrition, and fundal massage will also encourage that involution. There are several things that can inhibit or delay the involution of the uterus, and it can result in hemorrhage. That's a full bladder. Or other factors that can lead to overdistension of the uterus, such as grand multiparity. In other words, mom has had multiple babies. Polyhydramnios, which is extra amniotic fluid. Excessive analgesics or oxytocin during delivery. Or the uterus is boggy or soft because it's not contracting efficiently. The woman may experience after pains, which are caused by contraction of the uterus during the involution. And with breastfeeding, it can be quite severe. It can also increase the duration and intensity of after pains. Even without breastfeeding, it can still be pretty severe and may require medication, usually some NSAIDs. Lochia is the vaginal discharge after delivery. It gradually decreases in amount postpartum, and usually by weeks 2 to 6, it's totally gone. We start off with lochia rubra, which is that bright red vaginal bleeding the first 3 to 4 days after delivery. Then it goes to a lochia serosa, which is a brownish or pinkish color during days 4 to 10. And lochia alba will occur after day 10 and is white or pale yellow in color. Now, women may not always follow the same time frame, even from pregnancy to pregnancy. So, just as long as it is not odorous or smelling rotten, increasing amounts, or passing clots, then it's probably okay. If those things happen, then mom does need to report that to her healthcare provider because it can be indicative of an infection. The ovaries. We know that ovulation can occur 3 weeks after delivery. If mom is not breastfeeding, her menstrual periods will usually begin within 6 to 8 weeks. But if she is breastfeeding or lactating, her menses may not return for up to 18 months. However, it is really important to educate women on on birth control methods, because breastfeeding is not an effective method of birth control unless mom is very religious in breastfeeding every 2 hours throughout the 24-hour period. The vagina may have small tears and it might be smooth in texture, but that rugae will return usually after 3 weeks. That rugae is kind of that rippled texture of the tissue. We do encourage Kegel exercises to help restore muscle tone. However, it's never going to return to its pre-pregnant state. We can get close, but also be aware that breastfeeding can lead to vaginal dryness. If an episiotomy is done, those sutures are absorbable, so they're not going to have to go back in and have the sutures removed. And it will take a few weeks for that episiotomy to heal. And same with the laceration. With the breasts, during pregnancy, mom may or will start producing colostrum, and some of it may actually leak from the breast during pregnancy. But after delivery, this is what mom will be producing the first 1 to 3 days postpartum. And it is an antibody-rich breast secretion. It's yellow in color, and it's a precursor to the breast milk. Because it is so rich in antibodies and nutrition, we refer to it as liquid gold. Suckling at the breast by the newborn will cause prolactin levels to rise, and this will help stimulate milk production. And we need to encourage mom to breastfeed the first 1 to 3 days every 2 to 3 hours. This will help that milk come in and also helps prevent engorgement. The milk will normally come in on day 3. With the cardiovascular system, during pregnancy, mom carried around a lot of extra fluids. And during delivery process, she has had a loss of that extra fluid. And that includes not only the water retention, but about 300 to 500 mLs of blood loss with a vaginal delivery, and 500 to 1,000 mLs of blood loss with a cesarean delivery. We can also see hemoconcentration, which occurs in an increase in hematocrit. We see other changes in our blood level count, such as an increased plasma fibrinogen or white blood cell count. Mothers postpartum are at an increased risk for blood clots, and she may experience chilling due to a hormonal release, and warm blankets are really good at helping calm those. As for vital signs, temperature can be elevated, but if it's over 100.4 after the first 24 hours, it does require intervention. Blood pressure should remain at the baseline levels, but be aware if mom had preeclampsia, her blood pressure may be elevated. And if she suffered hemorrhage, her blood pressure may be low. Her pulse also might be on the slower side. After delivery, mom will experience some weak abdominal muscles. She may have that diastasis recti abdominis, which are those abdominal muscles that separate during the pregnancy, but be aware this does not occur in all women. We treat it with exercise. Women are often very hungry and thirsty after delivery, and constipation can be a problem for various factors. Maybe it was decreased peristalsis during the labor process, or if she had any injury or episiotomy to the perineum during delivery, she has a fear of pain, so she suppresses those bowel movements. Or maybe she's on iron supplements. All of those can cause constipation. Now, usually mom is going to excrete a lot of that excess fluid volume through urination. But maybe she experiences trauma during that birthing process, and that can lead to a temporary loss of bladder sensation, and that causes urinary retention or painful urination, so she doesn't want to go. And this increases the risk for urinary infection. With the integumentary system, she may have diaphoresis and night sweats as another method to help get rid of some of that excess fluid. And on the abdomen, thighs, and or breasts, she may have those stretch marks or stria. If she had that linea nigra during the pregnancy, that darkened line from the umbilicus to the pubic bone, that will begin to lighten after delivery. Mom can lose 12 to 14 pounds at delivery of the fetus, placenta, and amniotic fluid, and then lose an additional 5 to 15 pounds in the early postpartum period. But the average woman will return to her pre-pregnancy weight 6 months after childbirth if she was in the recommended weight gain limit of 25 to 30 pounds. And breastfeeding women do tend to lose that weight a little bit faster than non-breastfeeding women. Just a little bit more information on the lochia. This slide helps demonstrate the amount of drainage there might be, how much lochia, and how to describe it in your documentation. The internal os of the cervix is usually closed a few days after delivery, and it will heal by week 6. If you look at these pictures, picture A shows a pre-pregnant cervix. It has that nice little round shape, but after delivery, in all postpartum women, if they had a vaginal delivery, they will now have a slit-shaped cervix. If mom had an episiotomy, just a mnemonic to help remember what to assess for. We have a 26-year-old gravida 1, para 1, in other words, 1 pregnancy, 1 delivery, who's delivered a healthy baby girl, and you're providing client teaching. One of the subjects that you know to cover is the restarting of ovulation and menstrual cycles. So one point you need to stress is D. You can conceive even if your periods have not restarted. So we not only have physical or physiological adaptations to pregnancy or postpartum, but we also have psychological. And understand that the role change is the most significant adaptation that mom has to make, especially if she's a first-time mom. Each child will be unique, and the whole family has to adapt to this new addition. Nurses do have the ability to influence the development of positive family relationships. So as a woman becomes a mother, this happens in stages, and we know that that beginning attachment, which is the result of the bonding process and preparation for that infant, happen during pregnancy. There's an increasing attachment that occurs as the mom learns to care for her infant and goes through the physical restoration during that early postpartum period. And mom continues to move towards what is now a new normal for her. She will achieve that new maternal identity no later than around 4 months. So we need to encourage new moms to identify and embrace her and her infant's normal. And don't try and be like someone else. What's normal for her may not be what was normal for the person she's trying to emulate. We need to assist new mothers to perform newborn care with the nurse's guidance. Our way is not the only way. There are more than one way to do things. As long as mom and baby are both safe, then offer praise and encouragement. In the development of family relationships, that attachment is the bond that happens between the parent and the infant. And it's a process that takes time. Bonding is a very healthy process. Something to encourage that attachment process is the on-face position, where we are making direct eye contact with the infant. And the amount and type of social support available needs to be determined, because this really does help with that relationship. And bonding is not just between mom and baby. It involves all members of the family. Something that we do need to educate our moms about is postpartum blues. This is a temporary condition. It can last 2 to 3 days, but should not last over 2 weeks. Mom may be sad or tearful for no reason. She might be irritable or anxious. She may have difficulty sleeping or eating and have decreased concentration. If her symptoms last longer than 2 weeks or become severe or start to interfere with her usual daily activities, she needs to seek medical care. This can lead to postpartum depression, and that is a medical emergency. So be aware also of cultural differences, because that can affect attachment processes. When providing care to postpartum client, it's important to assess the new mother's psychological adaptation to the infant. You know that there are 2 critical elements to becoming a mom. What are one of these elements? And that is engagement with the infant. So how do we assess someone who has just had a baby? Most women who deliver vaginally are going to be discharged within that first 24 to 48 hours and 72 hours after a cesarean delivery. So they're not in the hospital very long. So it's essential to do a thorough data collection to detect any complications so we can address those prior to them going home. Data collected prior to delivery is going to form that baseline. And we do this at least once a shift. And we also complete a head-to-toe exam once a shift. We need to monitor the breasts, the uterus, the lochia, bladder, the bowels, the perineum, the lower extremities, any pain, any labs, the bonding process, and maternal emotional status. So that first hour after delivery, one of the things we need to do is prevent and detect hemorrhage, which will occur most often in that first hour. This includes monitoring those vital signs, the position and firmness of the uterus. How much lochia is there? Is there bladder distension? What do the perineum and surgical incision look like if those are appropriate? We need to prevent infection, and as always, hand washing is the first and foremost weapon in infection prevention. Promote sleep and promote that healthy parenteral and newborn attachment. With the breasts, we're looking for engorgement, redness, cracks, any painful areas. And we need to determine if the nipples are erect or inverted if mom is breastfeeding, because that can affect how that baby latches on. We should encourage mom to empty that bladder prior to assessment of the uterus in the supine position. We're assessing the tone, position, the height of the fundus, the appropriate response if we massage, it should firm up. And if she had a cesarean, make sure you check the incision in addition to fundal massage. With the lochia, we're looking at the amount, the color, is there any odor? And don't forget to look at the buttocks for pooling because, again, gravity, blood is going to go down. Notify the RN if she's saturating more than 1 pad per hour. And realize that with a cesarean delivery, usually there's not quite as much lochia. We need to note the amount and frequency of urination. Is there any urinary retention? Because it may require a potential catheterization. We should auscultate for bowel sounds. Ask about passage of flatus or bowel movements. Because remember, fear of pain can lead to constipation. Make sure you encourage that adequate fluid intake, early ambulation, and a proper diet. To assess the perineum, we assist mom into the Sims position, and we need to inspect for redness, edema, ecchymosis, and if she had an episiotomy, assess the incision and assess for hemorrhoids if those are present. The lower extremities, we need to be looking for edema, making sure pulses are equal, cap refill. Look for potential DVTs. So we're looking for pain, warmth, or redness in the calf. Assist her with ambulation, and maybe we're using compression devices. Now remember, mom had a lot of extra fluids during pregnancy, and during delivery she's lost quite a bit of these. So she can have postural hypotension. Make sure that you dangle her prior to getting her out of bed so we're aware of whether she gets dizzy or lightheaded, and assist her as needed. We do not allow mom to get out of bed by herself without nursing staff there the first time until we're sure that she is recovering appropriately. And also use caution when she showers for the first time, because remember, most people shower with warm water that causes vasodilation, which can increase hypotension. We need to assess her pain. Where is it coming from? What are the characteristics and quality and the timing? Then provide comfort and pharmacological pain measures if required. Do that fundal palpation. And we know that and exhaustion can both contribute to pain. If she has breast pain, is it bilateral versus unilateral? Is she breastfeeding versus bottle feeding? What are the condition of her nipples? With after pains, we often give ibuprofen or other NSAIDs. We can use non-pharmacological methods, and understand that if mom is breastfeeding, not only will she have after pains without breastfeeding, but breastfeeding can increase those after pains. With perineal pain, does she have a hematoma, infection, swelling? What is the condition of the episiotomy? We can treat that with sitz baths, medication, or ice packs. After a cesarean birth, the anesthesiologist often will manage the pain for the first 24 hours post-delivery. Breakthrough pain, maybe we're using a PCA pump. Maybe she's getting PRN narcotics. If she is breastfeeding, we need to be cautious that we're using appropriate medications. And there's also an increased risk for gas pain due to decreased peristalsis from the surgery. We need to monitor labs, maybe the H&H. If she's Rh negative, she's going to need that RHOD immune globulin injection within 72 hours of delivery for it to be most effective, also known as RhoGAM. Look at her rubella status. If she's non-immune, she's going to need that rubella immunization prior to going home. We assess bonding. We're looking at the maternal-newborn interactions. We're looking at interactions during infant feeding. And again, beware of the woman's culture. Determine the quantity and quality of her social support, and ask her about plans and preparations for infant care. May require some education. And we monitor the maternal emotional status. What is her mood and affect? Make sure that we're reinforcing information concerning postpartum blues, depression, and promoting restful sleep, and looking for other factors that may contribute to emotional stress. So true or false? The RHOD immune globulin is given to an Rh negative mom who delivers an Rh positive baby to prevent the formation of antibodies that may attack future fetuses. And that is true. So, once again, remember, mom is not going to be in the hospital for very long, and discharge planning starts at admission. Most interventions focus on informing the woman how to care for not only herself but her baby. We watch for interactions between all the family members and note if any actions are getting in the way of positive adjustment. Determine the woman's knowledge base and provide information as necessary. Reinforce those positive family behaviors. Provide any assistance as needed to help mom learn new skills, and provide positive verbal support. You know, we never anticipate that a mom who is a repeat mother knows what she needs to take care of herself or her baby. So we make sure that we educate on everything and are watching for any knowledge deficits. Safety is going to be the most important thing, not following the nurse exactly. Again, our way is not the only way to do things. And if it's working for mom and working for the baby, then by all means let them do it as long as they're safe. Make sure that we set aside time for big sister and big brother. Remember those cultural differences. That short time period prior to discharge is very short, so give small sections of information throughout the stay, and don't anticipate that they're going to remember everything you tell them. So we give them written information also. The things that we tell mom to call the healthcare provider for is if she has that temp over 100.4 after going home, the shaking chills, a localized reddened painful area on one breast, frequency, urgency, and painful urination. That sudden onset of shortness of breath and chest pain might be that pulmonary embolism. Severe, unremitting abdominal or back pain that's unrelieved by normal pain measures. And that foul-smelling lochia. Increased or heavy lochia flow or passage of clots. A return to lochia rubra after it has been serosa or alba. Severe pain, redness, or swelling in the episiotomy or cesarean incision. Swollen, reddened, painful areas on the calf. Prolonged or severe symptoms of depression. Again, this may include extreme sadness, lethargy, loss of interest in the activities, feelings of worthlessness or difficulty concentrating, or thoughts of harming the baby or herself, those suicidal thoughts. With breast care, make sure she washes with plain water. Maybe she needs to use a lanolin cream to help keep the areola and nipple soft and keep them from cracking. Or she can rub a drop of breast milk into each nipple and allow it to air dry to help toughen them up. If she's bottle feeding, we do not encourage her to express any milk because she will gradually stop producing, and the breast will replace everything that is removed. Fundal massage. Do a demonstration. Explain to her what to feel for. Help her find that fundus so she can perform this at home. But tell her that after day 10, she should no longer be able to feel the fundus. Teach her how to use the peri bottle. Basically, it is a bottle that we fill with warm water, and she rinses the perineum with warm water after she voids or has a bowel movement to help with infection control. Teach her to not touch the middle of her pad, to touch it on the edges to help prevent infection. She should not use tampons or douches or engage in sexual intercourse until she has been instructed by the healthcare provider. Teach her appropriate hand washing and to use birth control. Teach her how to control the pain before it becomes intense. If it becomes intense, it's more difficult to control. Explain all prescribed medications and the benefits of using non-medicinal ways of controlling pain. Ask her about her pre-pregnancy diet and give brochures that explain recommended amounts of the group or food group intake. Explain the difference for breastfeeding moms versus non-breastfeeding moms. And as a breastfeeding educator, we encourage mom to basically avoid junk foods or empty calories, to eat when she's hungry and drink when she's thirsty, but we do encourage at least 8 glasses of water a day. Knowing that constipation is a real risk postpartum, we encourage mom to engage in activities that will improve peristalsis and bowel movements, ambulation. Encourage non-caffeinated fluid intake and proper dietary intake, and the use of medications. We also encourage mom to get plenty of rest. So a lot of new moms think, oh, the baby's finally asleep, I'm going to get up and get something done. But encourage her to just rest when that baby's napping. Also reassure her that health of herself and her baby are most important. So true or false? Assessing the new mother's knowledge base is an ongoing process, and that begins at admission. Definitely true. And get ready for your post-test.